So,
Okay, I started the recording. Do you want to record
oh,
or
you
should
did? Perfect. Sorry,
I
I
just
just wanted to
started?
make sure
Yeah.
it was started. Okay, so I will stop now and you can feel free to take it away.
All right, sounds good. Well, before I start sharing screens, I'll just say hello, everyone. I'm excited to be here today and sort of elevate the voices of nurses in the realm of AI and health. Um, I previously worked for UW Health, one of the, do you guys call yourselves HYPE? Just let me say AI hype. I don't probably not. You probably don't want to do that, but the partnership here for 12 years, I worked with that organization. We're still strong partners, but I'm now at University of Wisconsin-Madison School of Nursing as a postdoctoral trainee and a clinical assistant professor, teaching new nurses informatics and about all these new tools. So I'm excited to share again the voices of nurses with some of my research work today. So with that, I'll just start sharing some of the slides. And again, it might take me just a minute to get you on the right screen here. 1 second. Let's try to the other one. Nope.
Yeah, we still see your notes.
Yeah, I'm trying to get it to take me to the, here we go. All right. How's that?
Perfect.
Okay, great. So again, hoping to just provide some information from nurses and their expertise to inform the design of AI for health for all of us today. I'll just let you know my spouse and I don't have any disclosures relevant to this work. Okay, so what I want to cover for today, I'll briefly cover some strengths of nurses and some of the challenges that they're facing today that I find relevant, to thinking about design of AI for health. I'll then present 2 of my research studies and share some of the insights based on our results. And then finally, I just want to conclude with, again, based on those insights, some recommendations as we move forward into future work in the AI for health space. So strengths of nurses, I could go on and on. This could take hours if I really wanted to, but a few that I want to bring up for those who aren't nurses themselves, just to emphasize again that I think can show what nurses can contribute to the design of AI for health. Nurses are really adept in turning data into wisdom. Since Florence Nightingale's Rose diagram, hopefully that's a figure that everyone is very familiar with, where she showed how epidemic disease caused more deaths among British soldiers than battle wounds did at that time in the Crimean War. Nurses have been using data to garner wisdom and advocating for patients, again, for hundreds of years. So they're very adept in these skills. Nurses are also innovators. So in case you didn't know, just to name a few, nurses invented the crash cart, color-coded IV lines, ostomy bags, and much, much more. So again, nurses are ready and willing to be engaged as innovators in the AI space as well. And nursing is a STEM discipline. It's really grounded in biological and behavioral science, and it's really a rigorous scientific education. Unfortunately, nurses are still sort of advocating at the national level to have this recognized as a STEM discipline, but if you ask any nurse, it definitely is. Unfortunately, there are some challenges being faced by nurses today that are probably a secret to no one. Here we see from a survey kind of the projected workforce shortages for the upcoming decade, which is pretty stark. Workplace stressors related to that and other factors. In this survey that went out shortly after the COVID pandemic, almost 52% of nurses were considering leaving their current position. And some of the factors, including insufficient staffing, just the work affecting their health and their inability to deliver quality care in today's environment. So important things to consider as we think about, where do we want to target our energies for AI for health? I hear this informally from nurses all the time that they don't get to spend enough time with their patients. I did find some data to sort of back this up. In this one study by Shank et al., they found that nurses were only in the patient rooms about 30% of their work time, or 35% of their work time. And that is really where nurses want to be. They want to be working with their patients. So some room for improvement there as well. And then nurses perceiving a lack of inclusion in decisions about AI. If you're not aware, nurses in California in April organized a really big protest because they perceived that health systems were really rushing into implementing untested and unregulated AI, and really had some concerns of what that meant for nursing practice and for patient safety. So they are advocates. They are watching and wanting to be involved. So just some things to think about as we move forward here in our discussions today. So next, I'll just give you an overview of some insights from a descriptive study that I and my colleagues conducted on nurses' needs, goals, and preferences. And this focused on machine learning-driven decision support tools. So just for some background, again, should be no surprise to anyone here that nursing decision-making is complex. As we all know, our patient data can be quite fragmented and difficult for any user to synthesize, and nurses included. We developed clinical decision support tools with the idea that will help synthesize and filter and garner insights. And then machine learning models are being, continuously considered as, for their usefulness in finding patterns in our data and hopefully driving high-performing decision support tools. But relatively little is known about nurse perceptions of these tools in particular. So the purpose of this study was just to explore nurses' perspectives around machine learning decision support design, its development, its implementation, and its adoption. So this was a cross-sectional qualitative descriptive study, and it was a convenient sample of direct care nurses that worked in acute care settings at an academic medical center. And we collected the data via virtual semi-structured interviews that were audio recorded and professionally transcribed. And then we used inductive thematic analysis as described by Brown and Clark, using the steps you see here to conduct the analysis. This is the composition of our participants. So you can see here we kind of have a variety of age ranges represented. Most were bachelor's educated, most were female and white. A variety of work settings, both critical care and more general care areas, and sort of a variety of years as a practicing RN. So these were the major themes that came out of this work. I'm going to dig into the bottom three that are highlighted just for the sake of time. The first theme, the one on top there, experiences in the technology ecosystem influence receptivity to new tools. This one really encompasses participant perceptions about their interactions with technology more generally, just to kind of level set for the questions more specific to machine learning decision support. We talked about how technology to date has supported or hindered their nursing practice and critical thinking skills, as well as their openness to trying new tools that are being implemented in practice settings. There's some sub-themes that go along with this one, but again, just for the sake of time, I won't dig into that one quite as much today. So let me get into the other three. So our second theme, convince me machine learning decision support matters. Tell me the why, so I'll try. So this theme really is comprised of nurses' recommendations for ensuring buy-in and successful change management when introducing these type of tools into their practice settings. So to foster the uptake of change for any new technology, but also specifically these tools, nurses really want to understand how it's going to solve a problem, how it's going to make them a better nurse, and how it's going to benefit a patient. So development team composition also influences their trust in these tools. So you'll see a quote on this here in a minute. In general, nurses just want to know the why behind what we're introducing. I don't think this is new information to us, but it's still important when we're thinking about deploying these type of tools. So if we dig into some of these sub-themes, patient benefit realization, you can see the quote here for participant 5. It just helps with the buy-in process. It needs to be applicable to the patient population. So sometimes I think we make some missteps when we throw out a tool that we think is going to work all across the organization. And there might be some special populations such as psychiatry or oncology where those tools just aren't a good fit. Evidence of novel insights. So as participant 9 is saying here, it's kind of a representative quote. What will matter to me is if it helps or not, if it's correct and if it can, predict sepsis and not be a nuisance and maybe catches it before I catch it. So really it's got to help me be better. Don't tell me something I already know. And that's something I heard a lot speaking with nurses about these, that some of the tools that are being presented with, they already know those things. So it's just, it's noise. So we've got to make sure these are really on target. And then trust in the development team, nurses and others. While nurses recognize this is an interprofessional team to develop and design one of these tools, they really want to know that their discipline is included and help shaped it. It helps them feel more confident in the tool. So this is really worth, supporting by both healthcare leaders and the design teams, as well as advertising. Sometimes nurses are involved and it maybe just doesn't get the word out that that's the case. So really making nurses the change champions of some of this work could really help with buy-in and trust. All right, moving on to the next theme. Nurse grasp of machine learning decision support shapes practice integration. So I asked nurses to explain in their own words, how machine learning models work. I was curious to see where they were at with their understanding of that. So we can see here we get kind of a variation. So participant 5 has a pretty good grasp, really, an intuitive grasp of how these tools work. Then unfortunately with participant 6, they're getting a risk score in this case, working off a machine learning model, but it's just a number to them. They don't really know where it's coming from. So quite a bit of variation with regard to nurses' current understanding, at least in terms of these type of machine learning models. And then in terms of talking with nurses about their information needs to be able to skillfully employ this, they want practical, kind of to the point information. They are interested in the factors that go into it. They want some background into why we're doing this, but they did emphasize it needs to be succinct, right? That again, their time is tight. So finding the most salient information to get in front of them is also important. I didn't include it here, but I had one nurse kind of make a nice analogy where they're like, I have this, cell phone in my pocket and I use it every day. I don't know the intricate details of what makes it work, but I can still use it effectively, or I know kind of, when it's, not working properly. So kind of finding that sweet spot for AI-driven tools, I think we're still working on it. And then finally, I thought this was an important insight from nursing. It needs to be more than a score. So in this case, oftentimes we're talking about risk identification by machine learning models. It really needs to guide them to action. So, in this quote, okay, cool, now what? So you're not going to give me information as far as ways to help guide my practice and mitigate that? So again, it's not enough to just identify risk. We need to tie that to the care pathway and the next steps to, sort of make that guidance toward mitigating, the risk or whatever it is that the AI tool is targeted to do. So taking that a step further than sometimes we have been. Okay, and then on to the final theme, nurturing nurse autonomy in an evolving decision-making landscape. So this theme really synthesized nurse self-reported identities as decision makers, including their role in this case as risk identifiers. It also encompassed nurses' perceptions of their own decision-making autonomy, with quite a lot of variation there. So some really perceiving that they still had a lot of autonomy in the workplace, while other nurses kind of perceived a loss of autonomy in their decision-making over time, largely driven by metric-driven standardization and prescriptive provider ordering practices. Nurses also expressed an interest in being able to make decisions regarding the output of machine learning model decision support tools, and wanted a mechanism to, kind of raise the red flag if something, was incorrect, and be able to dynamically engage with these tools to train it. So if we look a little more detail in terms of what nurses are saying, again, this participant, provide an example where they felt they still did have autonomy, even though these, they might get some identification that the patients at high fall risk, they still felt like they had autonomy in their own decision-making, to sort of override that if their assessment was different than that of the tools. Nurses it was sort of varied whether or not nurses identified this risk prediction as even a part of the decision-making they made every day. About half of the participants kind of expressed that when I asked them about, to describe the decisions they make in a typical workday. So that sort of varied, and that kind of makes me wonder about, nursing and their interest in delegating this kind of task to these type of tools. And then nurses' data as model inputs, that requires stewardship. So I did ask the nurses to think about the data that they're generating and whether or not they would want to let data science teams know about any data they might want to move forward with caution. So in particular, nurses talked about their behavioral assessments and how much that might vary from nurse to nurse. So we can see the example by participant 2 here, kind of reflecting this. Using the nursing assessment data makes me a little skeptical. I can assess a patient and my colleague can, and it may come up very different things. So again, most of the time talking about sort of behavioral assessments in that regard. Also a lot of excitement, I have to say, by nurses about the thought of their data being used for, training and for AI tools, because I think we all know that nurses have a general sentiment that they generate a lot of data that doesn't get looked at. So I have to say there was also some excitement by nurses that their data that they work so hard to generate might be more leveraged as we look to train some of these tools. And then finally, I think this is really great insights. So a couple of the nurses really talked about wanting dynamic engagement with these tools. So, frustrating to be told things they already know. So this participant in particular talked about a button they could click and be like, hey, this is normal for this patient. What you're telling me here doesn't make sense. And, help the program learn that patient's uniqueness, hopefully improving the model overall for safety and efficacy. So really, again, great idea here from nurses in terms of how we could design these tools to be even safer and more effective. All right, so wrapping up here on study 1, just with some key takeaways. Again, I think nurse involvement is key. Findings from our study suggest that involving nurses in the design and development will foster trust by nurses in those new tools and some buy-in, and then also provide insights again into the potential biases in nurse-generated data, which data might be valuable to leverage. Again, nurses really have a lot of important insights to convey and share. We did find, based on our findings, it suggests that there's still some gaps in knowledge to be filled and to enable nurses to use these tools effectively. So we do still need some competency building and governance structures to really help nurses effectively evaluate and use these tools. And then some ideas for future work. Again, let's think more about these real-time feedback mechanisms. How can we make that a reality? I'm seeing this a little bit on the vendor side, some thumbs up, thumbs down for some of the newer tools that are coming up. But I'd like to see some more robust examples of opportunities to provide that real-time feedback so we can really move quickly towards safer and more effective AI tools. All right, I'm gonna break now and move into study 2. So this is a study that looked, took a little bit different shift, looking at nurse satisfaction with clinical decision support driven by machine learning and the explanations that we're using to help our end users understand those outputs. So again, already talked about, we know these, why we're trying to use these tools. Hopefully it's helping support good decision-making. I think everybody maybe attending here today knows that machine learning models can often be considered black boxes. So there is an explainability challenge that can hinder effective adoption of these tools. We try a lot of strategies to try to explain these outputs to our clinicians. One that we use most often, I think, from my knowledge, is local feature importance, where we're sort of representing the inputs that go into the model, perhaps with some weights that were important for the identification of risk for that particular patient. And then just recognizing that nurses are often the target users of these types of systems, particularly these risk prediction systems, but their preferences really have been somewhat understudied. So we had several aims for this study, but I'm going to focus in just for today, again, just for sake of time, on describing nurses' current level of satisfaction with these explanatory information displays that we're tending to use for machine learning derived decision support tools. So again, this study was a cross-sectional descriptive design. It was a convenient sample of direct care registered nurses working in a larger US Midwestern health system. And we recruited them via their work email addresses and gave them a small monetary thank you for their participation. In this case, we used a web-based factorial survey procedures to collect the data. So these are the main steps, and I'll get into each step in a little bit more detail. So essentially, the nurses who participated and were screened to be eligible would read information about a machine learning decision support model. They'd read through a really brief, kind of synthetic narrative patient scenario. They'd be randomized to review one explanatory information display and then rate the level of satisfaction with that display, and then ultimately shared some demographic information about themselves. So this just gives a little more information about each step. Again, they received some information about the models, such as training data set, risk thresholds, testing outcomes. I don't have enough space in the slide to show the exact words that they got a chance to review, but that's the type of data or information that was covered. And then this is just an example of one of the scenarios, the narrative scenarios that they would read through. Again, not important to read this word for word, but just so you have an idea of the level of information they received for this study. And then again, I know these are very tiny and you don't need to see all the little, the contents of each of these displayed, but essentially just know that they were randomized to receive, we had two scenarios, either fall risk scenario or clinical deterioration scenario and model that we were inquiring about. And then we had simple displays versus complex displays, and then tabular displays versus displays with more graphical elements. So just kind of looking to see if there was some variation there in terms of nurse satisfaction based on those features. And then to rate satisfaction, again, this is more than just like a thumbs up or a thumbs down. We use the Hoffman's explanation satisfaction scale. So this is an 8-item, 5-point Likert scale, getting into domains of understandability, feelings of satisfaction, sufficiency of detail, completeness, usability, usefulness, accuracy, and trustworthiness. So covering quite a bit with each of the items in this scale. And you can see just one example item here. This explanation of how the machine learning model works has sufficient detail. So then we'd rate on each of those 8 items. And then finally, we did collect some information about our participants, including, demographics as you would expect, years in practice and work setting, et cetera. And then also level of training in using technology driven by AI or machine learning, and then frequency of use of technology driven by AI or machine learning. So again, this is really brief here, but basically descriptive statistics for aim 1. Again, I kind of took out what I had in here for aim 2 since we're not getting to that today. But feel free to ask me about that later if you're curious. So we had 332 nurses participate in this study. Again, you can see the majority of the participants were female, white, and bachelor's educated, and under the age of 40. And then the majority worked in full-time roles with adult patients in hospital and inpatient settings. And the mean age working as a nurse was about 10 years, but you can see that ranged quite widely. And then I think this one might be of most interest to everyone, just kind of seeing that the health system where these, these were their responses to their level of training and the frequency of use of AI in their workplace. So of note, the health system where these nurses are employed have multiple AI-based decision support tools in production. One for sure is accessible to all the inpatient nurses. And again, we do have some outpatient nurses in this sample, but despite that, almost half the nurses stated they had not received training in the use of any of these tools. Although 10% of nurses did report that they use these tools daily. So maybe a bit of a mismatch there and work to be done. So I know this is tiny and really busy. This kind of just shows you the distribution of the explanation satisfaction scale responses across all the different participants. So you get to see what each of the actual items was, the mean and standard deviation, and then just kind of centered on the neutral there, just to sort of see that distribution. I'll focus in on these three where we still have a bit more work to do. So the one that had the, a higher number of nurses sort of disagreeing with the statements were for this machine learning model tells me how to use it, or this explanation of how the machine learning model works tells me how to use it. The explanation of how the model works shows me how accurate it is, and it tells me if I should trust or not trust the model. So still some work to be done in finding ways to help nurses understand that utility and accuracy and to build that trust. And then just also in terms of kind of some of the different correlations we looked at in terms of participant characteristics and their satisfaction with explanations for these tools. We did find that age was negatively associated with nurse satisfaction with these explanations, whereas level of training was positively associated with nurse satisfaction with these explanations. So just kind of gives us an idea where we might need to target our efforts with our training. All right, so finishing up with some key takeaways from this work, still do have some explanation insufficiencies. We find our results suggest that current explanations of machine learning decision support in particular may be insufficient to meet the information needs of nurses, particularly in the domains of utility, accuracy, and trust, as I mentioned and kind of pointed out. And then also that the level of training, it's positive associated with nurse satisfaction with the explanations for these tools. Future research could explore nurse competencies in AI and how that influences hopefully not just satisfaction, but also effective use of AI-driven decision support tools. So still lots of room for more work. All right, so let's kind of bring those results all together in terms of, getting nurses at the table for providing insights to guide our use of AI for health. So looking back at some of those key takeaways, I would just like to bring in some 5 core recommendations for health systems and anyone working in this space. So again, nursing involvement being key. I'd like to see nurse leaders and design teams really support and ensure direct care nurse involvement on design teams. So again, I really want to emphasize there that direct care involvement. Those are the nurses that know how these tools are likely to affect workflow or particular patient populations, whereas we might have nurse informaticists on the team. I can say for myself, I haven't been myself at the bedside in about 8 years, so I think it really is important to have that direct care nurse involvement as well. And then really to advertise this involvement at that time of deployment so that other nurses know there were nurses on the team. I think that really is going to help with that change management and that buy-in and trust. And we don't maybe always do a good job of making that as known as we could. All right, moving on to the next one. Nurses are experts in the data they generate. So again, design teams really should work to leverage that nurse expertise. Nurses generate a great deal of data that could be leveraged to train AI tools. They're going to know the value of that data and also, again, the risk of the potential biases within that data. And so there's an opportunity to really get nurses involved, I think, earlier in some of these design teams. You know, in the case of like a machine learning model, getting them involved in the feature engineering and determining, you know, which inputs are going to be clinically important to improve, again, that clinical validity of these tools. Moving to the next one, gaps in nurse training and knowledge about AI persist. I would really recommend healthcare systems partner and collaborate with nurse educators to develop training AI for currently practicing nurses. Again, as a nurse educator myself, we're working on this for our nurses in our nursing schools right now. But for those who have already left our doors and have moved on into practice, I think there's still a lot of gaps to be filled in terms of nurse competencies in AI. And I know I'm working with my local academic medical center and hope that other health systems will aim to partner with nurse educators to develop content to support their nurses so that they can effectively use and evaluate these tools. And then again, I've got a lot of excitement for this idea of nurses for real-time feedback mechanisms. You know, really using nurses, getting nurses an opportunity who are, you know, using, testing, piloting these tools in practice to provide that real-time feedback mechanism. So kind of going beyond, you know, maybe the post-implementation surveys you might do, or the, you know, maybe the rounding, but, you know, maybe day to day, just really having a mechanism to provide real-time feedback and then hopefully catch any safety concerns or drift and really helping to foster a quicker turnaround to, you know, the safest, most effective models that we can develop. And then finally, current strategies to explain AI solutions to nurses are currently insufficient to meet their information needs. So again, our findings would suggest we've got some work to do, you know, and in terms of assessing the competencies of our target users and making sure that the information that we're providing to them at the time of deployment and ongoing is really meeting their needs. So again, we should all work together to find best practices moving forward kind of in this realm. All right, so kind of wrapping up here, because I'm looking forward to having some time for some discussion with the group. You've maybe all seen the viral post, I want AI to do my laundry and dishes so that I can do art and writing, not for AI to do art and writing so that I can do my laundry and dishes. I definitely feel that way about AI and kind of some of the tools that are coming out, especially as an educator. So I took a stab at doing this for nurses, so that I hope we'll all kind of use as a take-home message. So, you know, I want AI to do my mundane tasks like finding supplies and administrative work so that I can use my clinical judgment to care for patients, not for AI to do my clinical judgment and care for patients while I find supplies and do administrative work. Again, there might be a more pithy way to put this together, but I think the take-home message that I want to make with that is, you know, really any tools that we're developing that use AI, you know, where we're spending our energies and effort and money and time, should we, you know, maybe support clinical judgment. But ultimately, you know, what I think nurses would really want is to automate or reduce time spent on administrative or mundane tasks so they can spend their time working at the top of their licenses and caring for patients. That's why we nurses go into nursing. And I think that if that's our goal and vision, AI could really play a pivotal role in reducing nurse burnout and reinvigorating some excitement for the profession. So I do hope as everyone on the call today who's working on tools for AI for health will really take that home as in terms of where we're spending our energies as we think about clinician work. So there are some references in case you want to check some of those out later. And I do want to acknowledge, again, all the nurses who participated in the study. Many of them participated during COVID, and so it was just amazing, their engagement and interest in being involved in this work. And I'm so honored to share some of their voices today. And then I do want to thank the funders that are listed here. And then you'll have my information if you want to reach out afterwards. But other than that, I think I'll stop sharing just so we can sort of have a discussion together.
So thank you so much for the presentation, Dr. Wieben. And the chat has been very active. I am going to let folks take turns to ask questions. So feel
Any
free
questions?
to come off video. Oh, I think, did she freeze?
It looked like Anne froze for a minute there when she was talking. Anne, can you
Yeah.
still hear?
Anne, can you hear us? Wow, the timing of that right at the end. Okay, we will give her a minute to try to rejoin maybe. But yeah,
She just left, so she might be.
yeah, she'll probably rejoin if but yeah, for the questions, if folks want to come off camera, introduce themselves, but we'll give her a moment to rejoin. Unfortunately, I feel so poorly equipped to answer anything that anyone would want to ask her. So we'll wait.
I guess one question is, what about Hippocratic AI? I heard they are training like a large language model nurse.
So Jan, I feel like the $9 nurse and the advertising around that was definitely part of what caused the mayhem. Okay. Bye, Bob. I did just send her the info, but maybe. She did tell us that she was in Germany for this call. So unfortunately, we'll give her another minute. She can maybe call in.
Did you email her?
Yeah, I did. Yeah, but I'll send her the phone option now too, just in case.
Hi, my name is Tracy Coleman. I don't have a good voice, but I know Dr. Wieben pretty well from our circle. So I will certainly give a response to that last question, that Hippocratic AI. I would just hope that a nurse was involved in the process, as Dr. Wieben kind of just shared, but it doesn't sound like it by the way nurses have reacted to it. So I just am so grateful that you all have had this forum for Dr. Wieben to share specifically from the nurse's point of view.
I mean, one question that I did have that I was going to ask her, but I feel like other folks on this call may be aware, because a big thing that we're trying to do through Health AI Partnership is to surface the best practices and where are there organizations doing this in a way that should be visible and shared. I'm curious because I know that there are a fair number of nurses on this call. What have folks seen that they find encouraging in terms of nurse education and engagement leading up to implementations or during implementations of AI software?
Well, I don't have an answer to that question, but I have a question that I think is somewhat relevant. And my question to her was going to be the nurse pool that she pulled from. I'm very curious as to where they practice, like if it was mostly in acute care or clinical, because my answer to your question would be very different based on where nurses practice. You know, if they're practicing in skilled nursing versus a hospital, the answer is going to be different. And so I was just curious, versus, you know, an outpatient clinic. That was going to be my question to her. Like where did these nurses practice?
Got it. And she is trying. Oh, here she is. She made
Yeah,
it.
sorry. Did you hear anything? Or did that just happen at the end?
And we heard your entire talk.
Okay.
And then at the very end, And I think, just FYI, your name is showing up as me because I sent you my link,
Okay.
but don't worry about that.
Oh, cool. All
we-
right. So sorry about that. I'm not sure what happened. Maybe it's just too far over the ocean today.
Yes,
All right.
well, I'm so happy you could make it back. So,
Yeah, sure thing.
I'll let folks, I told folks, please come off camera, introduce yourself, and feel free to ask questions. If you want to raise your hand with the icon, you can do that as well. Corinne, I saw you just came off camera. Did you have a question?
Nope, you just encouraged it. I'm eating my lunch. I joined a little late. I'm just here to say hi.
All good, all good.
Hi, I have a question. Can you guys see me?
Yes, we see.
Yes. Hi.
Okay, hi. My name's Michelle. I work at a community health clinic in Minnesota. I'm an informatics nurse. My question was, and it was in response to Mark's question Mark posed, which was, what are some of the best practices that we're seeing surrounding AI in our workspaces? But my question to you was, where were the nurses that you interviewed practicing? Like, were they mostly in acute care? Were they mostly in skilled nursing? I've worked in a variety of settings, and I can tell you that, you know, the training on this is vastly different depending on where people are practicing. So I was just
Yep.
hoping you could speak a little on that.
Sure. For that first study, those nurses were all inpatient, like direct care nurses, because I wanted them to have at least some exposure to one of those tools. And at that point in time, the organization I was working with didn't have tools in the outpatient areas or other care areas. For the second study, that was a broader enrollment, basically any nurse providing at least 50% of their time in direct care, whatever that care might be. It could have been telehealth, it could have been outpatient, inpatient, but again, within one Midwestern health system. So that would not have included any school nurses or public health nurses or anything like that. So yeah, I didn't really spend a lot of time on limitations. Of course, there are limitations to the study, but unfortunately those weren't as represented in my work. So definitely room for further assessment, across the scope.
Were you able to pull from skilled nursing at all?
No, again, those weren't part of the organization that I was recruiting from. So again, more opportunity for future work for sure. And I was just in Minnesota for the Nursing Knowledge Big Data Science Conference, Michelle. You have a lot of really strong nursing informaticists working up there. It's a great place.
Yes.
Yeah.
Jan?
Next question, Jan. Yeah.
Yeah, how's it going? Can you hear me okay?
Yeah.
Okay, awesome. And then let's see if I can actually screen share. There we go. So I'm commuting. So my question was for the nurses in which you collect their backgrounds and kind of the skilled nursing facility question, like you don't have nurses in skilled nursing facilities in the study right now, so there's some unobserved confounding where you don't observe that the nurse might not have interacted with a very discriminatory clinical decision support or prior authorization algorithm. So then their willingness to do certain procedures over others, or even the ranking of certain like best practices advisory alerts or the ordering of pop-ups sometimes is correlated with things like being a member of an accountable care organization or being part of a private equity backed nursing home. So those kinds of unobserved confounders, how do you think we should include those? Because we are starting to look at some of this data.
How should we include those groups working in these other?
Yeah, or how should we include this kind of structural, like I forget the word, structural humility factors in assessing like kind of the operational community's ability to detect and mitigate bias in clinical decision support.
And then are you asking specifically for those communities of nurses that weren't represented in my data, like skilled nursing facilities and those groups?
For example, yeah.
Yeah.
Because if you put a nurse who has not worked in an inpatient psych ward in an inpatient psych ward, and then you tell them that, hey, Medicaid will cover inpatient psych stays at this rate, while private pay will cover inpatient psych ward stays at this rate, you're any AI algorithm will just say like, okay, like they'll need long-acting injectable antipsychotics and they'll have to go home within 2 days. So that might not be the best course of clinical action, but it is the best course of financial action. So a lot of the
I
work we
see.
do is like addressing those kinds of like conflicts of incentives. And it's very hard to do transparently. Like best practices advisory alerts are sometimes ordered by reimbursement rate, which is a big no-no, but kind of is inevitable.
I see. I mean, I think I understand your question, I'm not as familiar with the type of tool that you're speaking of, but again, I would say that for myself, that's all the more reason to have nurses involved as advocates in terms of when we're developing these tools. I think sometimes when it's left up to the data scientists, it might seem like a good idea, but they could, definitely provide insights on all the different patient level considerations as to why it's not so cut and dry and black and white. And kind of bring in that patient advocacy component. And again, sometimes I think we're often bringing in nurses or social work much too late to kind of catch the populations or the scenarios where it won't work as black and white as we might think. Does that help?
Yeah,
Great
that is
specific
super helpful.
examples.
Thank you.
Any other questions? Murtasa, did I supposed to say your name correctly? Hi. Oh, thanks for sharing that, Yana. Look forward to looking at that.
Oh, yes, there we go. Can you hear me?
Yes. Hi.
Okay, so hi. No, thank you for the excellent presentation and the important views of the nursing team and the nurses and how we move forward in this field. I had a question on the explainability work.
Yeah.
One of the issues that I've heard about is that even if the explainability it provides an explanation of a proper explanation of what's going on, clinicians might still just go with what their own concern is, or there just might not be time to actually look through the explanation to make these decisions. Did you get feedback like that? And also, sometimes the response might be that we believe it, we trust it, but it's not going to really affect how we make our clinical decision. Because I think the questions you asked was more about, do you understand the machine learning model, but will it in the end affect the clinical decision? What are your thoughts on that?
Yeah, good question. So in terms of the explanations, I think there's still, and I would ascribe to this as well, a debate on how much do we need to explain it, right? Like I mentioned that quote from the nurse, like I have a phone in my pocket. I don't know how it works, but I know how to use it. And they might say the same about a pulse ox or any of the other kind of technology that they're already using in their practice. It's more about knowing when it's, providing the correct information and support and being able to recognize when it's completely off the rails, right? So I don't know if that's where we need to focus our energy. I do have a study going on right now that's a higher fidelity study using like an electronic health record playground environment. If anybody wants to talk about that, it took like 8 months to set that up, but it's hopefully going to be worth it to really look, get beyond this question of satisfaction and really get more into, is it helping with efficiency? That we're having them do this kind of patient prioritization task. Is it really helping them make the best decision? So hopefully with some of that future work, we can get to some of those other questions with these more like high fidelity studies to really see how it's influencing that cognitive load or that actual decision-making processes. Again, this was lower fidelity, kind of just kind of gauging satisfaction, sort of getting the lay of the land. But I do think more work is needed to tackle some of these exact questions that you're talking about.
Yeah, thank you. I think as a field, we're just catching up in this area, or
Yeah, exactly.
we're trying to catch up in this area. So thanks for this work, even if it's not, the high fidelity work. And I'm excited to hear more about what you're doing right now.
Yeah. Thank you. Any other questions?
And I have a question about kind of
Sure.
educational models. And
Yeah.
so I have never been involved in a training program targeting nurses. I have been involved in one for medical students for many years, and I'm often asked the provocative question of, should every med student know how to code? And I know my answer to that, but I'm curious for you, when you think of kind of the different segments of how people will engage in this work.
Yeah.
Do you think every nurse needs to know how to code? Or do you think there's a subset that you think would benefit from being equipped with those technical skills?
No, yeah, interesting question. I guess my first question would be, do any of us need to learn how to code anymore? I know that I'm relying quite heavily on certain tools to help me out with mine. But understanding how it works, of course, asking, being able to get to the final answer. Yeah, that's a great question. I feel like in nursing right now, we have so far to go just to get nurses, build up the competencies in kind of nursing informatics, so like data, we still have some room to grow in that regard. Data literacy, I think next step would be that data science literacy and some of the things you're talking about. I don't know that every nurse needs to know how to code, but some awareness of that, for sure. And then I would love to see all of our, advanced programming, our doctorates in nursing practice, our PhD prepared nurses, absolutely having those skills. And again, that's still a deficit that I'm seeing. I can say for my own PhD program, I had to sort of search outside of, the nursing department to get some of that content for myself. But really, kind of building that into the requirements. So it's not just, something you could do extra if you're a nerd like me. I definitely see that as being just necessary. I mean, there's so many insights to gather from these data. And again, nurses need to be at the helm for exploring the problems, inherent to their own work and exploring the questions that they have. So yeah, I think absolutely, especially at those higher levels. And then again, data literacy, data science literacy, I think at every level for sure. Yeah, great question.
And Jim, I think you had your hand raised. We have time if you want to go ahead.
Oh, thank you. I had my hand raised, but Anne did such a wonderful job in her explanation that I didn't have a lot to necessarily contribute. But I was just going to comment on, yeah, I don't know if I would support the idea of nurses needing to code, but to Anne's point, their ability to explain a process, describe the data that goes into that process for their decision making, and then saying this is how ML could help us or what AI could do. That's a range of new awareness areas, as Anne hit upon. That's not just necessarily coding. If anything, the coding is getting to be more and more the easy part. It's all the difficulty around the business process optimization, the data science discussion, et cetera.
Yeah, agreed. And I didn't put it in the talk, I almost did, but I kind of just ran out of time. But if you look at the nursing process and you look at like design thinking processes, they're so similar. They're just using different words. So I just think there's a lot of overlap. I mean, again, nurses are innovators. I want to say they're like MacGyver, but I think that's an outdated reference. But if you see some of the things that nurses put together for patients. And so again, I think they're well equipped to jump into this space with the right baseline of literacies in terms of, the data literacy, the data science literacy, and then just the processes around building the tools. Again, coding, maybe not, but still some room to grow in our own AI literacy content.
And I have a question about Health AI partnership. So we just launched the Health AI hubs. I think we did our first one maybe in February. This is our third, fourth, fifth. We've clearly seen over the last 6 to 12 months that there has not been sufficient engagement from nursing in the development implementation of AI. What can a collaborative like ours do to elevate the voice? I mean, beyond bringing in speakers to kind of strengthen the way that nurse engagement is involved.
Yeah, that's a great question. Thanks for that. I mean, I think there are some, nurses are working, I guess, among themselves in this space. There's a nursing and AI leadership collaborative that I can think of called NAIL. Again, I was just in Minnesota at the Nursing Knowledge Big Data Science Conference, and that's a really strong meeting that's been going on. Nurses are involved in, EMEA and some of the, broader communities for sure. But yeah, I think, sometimes I'll attend things at, groups like yours, you know, there's a lot of groups evolving, right, with Kai and Train and like all these AI groups, but I see little nurse membership on a lot of those groups, so it's not just you guys. So again, I think knowing maybe the names in the space that are willing to raise a hand and be at the table. Again, nurses are eager to take part. And I think have a lot to offer. So yeah, beyond speakers, I think, yeah, any fostering of connections that this brings about would be great to get more people collaborating. Team science, right, is where we should all be at. So unfortunately, I see a lot of models getting developed. Again, the nurses are the targets, but were they involved in the research or the work? Nope. Or even thinking about certain vendors that are making models who might have thousands of employees and 35 of them are nurses. Like when you hear things like that, it's really pretty striking when like a electronic health record company isn't hiring nurses who are, really one of their key users, knowing that we are really the biggest healthcare workforce. Sorry, I know I'm rambling, but I hope that helps. I mean, again, we're here, we're ready, we're eager to be at the table. Again, that's why I sort of wanted to emphasize some of nursing strengths at the start of the talk, because again, we're intelligent, scientifically minded innovators who really want to help make the best tools possible and work with others on doing that.
Well, all I can say is firsthand, having built tools, the engagement of nursing is critical to success. So
yeah,
I want to go back to you. This is probably going to be the last question.
Sure.
Michelle?
Oh, hi. So it's not so much a question, but just a
Sure.
very short anecdote just to drive home this point. I was involved with implementation of a technology that I was working in skilled nursing at the time. And it was a wearable device that was supposed to it had multiple uses, but to sort of detect dehydration or fall risks, and when patients or residents sort of went from their baseline, like slipped from their baseline, and they had absolutely no doctors or nurses, but no nurses on their development panel. And so they missed something like for example, like a lot of skilled nursing patients don't raise their hand like this to drink. And don't raise their hand like this. And a lot of them don't take their own meds and things like this. I mean, that's just a point, just, an example.
Yeah, great example. Thank you, Michelle.
So let me just pull up the last slide. Next month, we have a totally different topic, which is going to be one that many of our sites have our heads spinning with. So let me share my screen. We have two presentations next month. One is about the patchwork of regulation. We're going to have some guest speakers from Manat who have created a pretty amazing health AI policy tracker. So that's linked on the website. That's going to be, we don't have the date here. Okay, no, July 25th. And then we also have our implementation evidence generation series with a presentation about, I think this one is pediatric asthma, on July 11th. So thank you, Dr. Wieben, and we are going to adjourn, and thank you everyone for making it today.
Mark, I know it's really last minute, but is there anyone who's involved with HAIP that's also involved with CHI now? Because I'm involved with some of the CHI working groups, and I'm starting to see some overlaps with what we're trying to do in the work groups there and what you're doing here.
So feel free to reach out to me, and happy to follow up on that.
Yeah, let's talk about it. Thanks, Mark.
Thank you. Bye, everybody.
Thank you, everyone.